Hello everyone, I'm Dr. Jung Young-eun. This is the case discussion. We share the clinical difficulties and find the best treatments. We have Dr. Kim Kyung-won, Dr. Kim Ki-sung, and Dr. Kim Young-taek. Thank you for coming. Hello.
그럼 오늘 고민 케이스를 만나볼 텐데요.
For the dental TV viewers, on the right of the video player, there is a real-time chatting window for you to post questions to us and share comments regarding the topics of discussion. Today's case, the patient is 49-year-old male, no systemic disease. After removing the implants number 26 and 27 in the upper left posterior, I want to place implants again. Which of the following two would be better? 1. After GBR, the height of the prosthesis will be made equal to the teeth. Number 2, implants will be placed as it is, and the prosthesis will be made long. On the panorama, here on the right, teeth are extracted. On the left, peri-implantitis is observed. On the right, 2 implants are placed in the residual bone without GBR using the second option described before. On the left, implants are removed. Next, if you look at the clinical pictures here, there is a very high vertical defect on the right. Looking at this, I believe the questioner dentist sent us this issue, what he needs to do on the left. What do you think, doctors? It looks very challenging. It looks very challenging to me as a prosthodontist. That's very challenging, whether we need to do the vertical augmentation, which is not easy to be done. So this requires a lot of thinking. As Dr. Jung said, implants were placed on the right and the crown became long. Therefore, the questioner dentist sent us this issue to be discussed. This looks like a difficult case. I will explain later, but I believe option 1 with GBR or option 2 can be done. We need to focus on the long-term outcome. So I will talk about that later. If there is a bone defect, bone grafting is not always the answer. We need to consider various things to come up with the optimal treatment for the case. Let's hear from the doctors how you would approach this. Dr. Kim Ki-sung? Okay, this is the frontal view of the patient. We need to treat the left posterior region, but I don't like anterior prosthesis with attrition. The question is regarding the left, and I prepared some solution. This is really a difficult case prosthodontally, and I have doctors who help me from time to time. This case is provided to me by Dr. Lee Hak-chul. For the posterior vertical defect like this, we can do the sinus grafting. Then we don't have to do the full-on GBR. I asked Dr. Lee to provide me with this kind of a case. Here, sinus graft is done and vertical height is gained to a certain degree. And then partial augmentation is done with the bone material to place implants. Even though the clinical crowns are a little long and it shows very stable result, another case, in quadrant 1, bone is lost. Likewise, sinus graft is done together with slight bone grafting on the concave region, not as much as full-on GBR. We need to choose one of two options. I believe the happy medium between the two can be the solution. This is my case. In quadrant 2, implants failed, similar to the case under discussion. So bone is lost. In this case, sinus graft is done and no GBR. Through sinus, vertical height was acquired and long clinical crowns are used. After the treatment, it doesn't look that bad. The crowns are not that long. And over time, you can see bone is growing from the bottom. When there is a big bone defect in the posterior region, if we do sinus graft, it can be addressed easily. Another case, Dr. Lee was invited to help me in my clinic. This was difficult because usually in the posterior region we have good gum and only bone defect can exist, but the soft tissue was not very good here. Pins were inserted and the GBR and sinus graft were done and implants were placed. Now this is the current stage. To treat soft tissue as well as bone, GBR was done. Sometimes I fail, therefore I invited Dr. Lee from time to time. This is the current status. What I want to say here is that the length of the clinical crowns, implants can have a little bit longer crowns. I am not skilled in GBR. In this case, this is 20 years ago. Number 5, clinical crown length is very long. If I waited a little bit long to grow bone, it would have been better, but I was very impatient in those days. But still, after 20 years, it survives. So it is used up until recently. I see this kind of cases a lot. Implants are placed after sinus grafting. I use short and thick implants. Crown-root ratio is not favorable, but I believe this is the right approach. I do the same in the mandible. I use existing bone for the treatment of the case instead of doing GBR. He made a very important point. Our dentists are too impatient sometimes. We need to wait. After extraction, if we place implants too hurriedly, before the vertical defect gets healed, it may end up as a failure. In this case under discussion, implants failed and the bone resorbed. If palatal bone remains after the extraction of a natural tooth, if we wait, we will get pretty good outcome. I will elaborate on that later. How long do you wait after extraction? In my case, when I was at a university hospital, my surgery schedule is quite tight. I cannot do the surgery right after extraction. Sometimes the backlog of surgery is like a month. Therefore, if you wait 2 months, soft tissue is healed and you can have more options. Dr. Kim Young-taek, you are busy with the surgery, so you don't place implants right after extraction, right? Right, I don't do immediate placement. Except for anterior aesthetic region, usually I waited 2 to 3 months for soft tissue healing and bone tissue healing. Soft tissue, I value soft tissue because I'm in the perio department. After it is healed, managing it becomes very easy. Waiting for a long time, may pose a problem in terms of the relationship with a patient if you're a private practitioner. I wait about 3 months. I think that's optimal period of time. I have some questions.
지금 제가 좀 몇 가지 저도 질문드릴 게 있는데 이 원래 롱 크라운을
If you make the crown long, the surgeon and the perio doctors like that, and you do GBR too. It is not to boast your surgical skill. That's because prosthodontists always ask us not to place implants deep to make emergence profile. That's why I do GBR, but listening to you, maybe we can think differently. I have a question. When you do GBR, if the soft tissue is mature, then you will have good blood supply after the closure. So do you wait about 2 months for soft tissue healing in the extraction socket so that GBR can be done after soft tissue is healed? I think if it is over 1 month, it will be okay. After a month, if soft tissue closure cannot be done, I wait for 2 months. In many cases, I wait longer because of my tight treatment schedule. Regarding soft tissue management, I'm not as skilled as a periodontist. I waited 2 to 3 months. GBR can be done, and soft tissue is okay, and bone can be healed. So let me explain with my case. Here, the patient, there was a bridge at number 16 and it fell off. I guess the previous doctor was not confident enough to do bone grafting at number 17, so he decided to place a short implant at number 16 using a lateral approach. But even number 16 became mobile. The alveolar bone at 17 was resorbed seriously, and number 16 failed. Therefore, the patient was referred to me. On the upper right side, on the panorama, this is March 2014. 3 months later, 23rd of June, it became mobile. The alveolar bone was severely resorbed at the beginning, but after 3 months, the bone has grown up, and I looked at it very closely to see what's happening. Palatally, there was some bone from the beginning. After 3 months, soft tissue and the alveolar bone at 17 became better because there was a bone palatally. If implant was placed 3 months before, it should have been placed very deeper. Anyway, he waited for 3 months, even though it wasn't his choice. So the bone became favorable, and 16 was extracted, and the patient was referred to me. CT, number 17, has become much more favorable compared to before. According to the standard lateral approach, actually, I make a small window. When we sinus grafting, for the bone to grow, the blood supply should be favorable. After window opening, the previous bone graft material grafted by the previous dentist was all scraped out, and the membrane was ruptured, and bone grafting is done to place implants. I placed allogenic bone on the sinus floor and cover it with bovine bone. 2 implants were placed at 16 and 17. You cannot see clearly here. At number 17, where big defect was before, buccally dehiscence defect exists. Using bovine bone, it is covered. autogenous bone from the lateral window, even the volume is very small, is put over the buccal defect. AOS graft, buccal lateral window is covered. I like fibrin glue, so sinus membrane rupture is repaired with it and is covered with collagen membrane, and GBR is done together. Immediate post-op 7 months. At the bottom, about 4 years later. Compared to the initial status, number 17 is not a good place to place an implant. Anyway, the doctor had to wait 3 months, even though it was not his choice. That worked pretty well. So using a minor lateral GBR, the result is very good prognosis and good crown length. Sometimes we have very good results like this, but in this case, this is a mandible case. The patient about 2 years ago at another dental office, implants were placed, number 36 and 37. Due to some reason, the implants were very close each other. After the placement and the prosthesis delivery, the patient complained the discomfort and the recurrent inflammation. That's why the patient was referred to me. I decided to remove the implants. Before the removal, we can see the gingiva had severe inflammation. We removed the prosthodontics and the flap was elevated. We have EFR kit available these days, but the implants were too close and we couldn't. Even trephine burr cannot get in, so very thin diamond burr is used to remove them. After the removal, the buccal plate is all gone. So as you can see, after the implant removal, the last panorama is post-removal about 3 months. Cortical buccal bone is all gone in the mandible. On the cone beam CT, there's some remaining cortical lingual bone. That's what made posterior treatment rather easy. 2 implants were placed. From the ramus, block bone was harvested. At number 6, where the exposure is the greatest, block bone is applied and bovine bone covers the site. I like the fibrin glue. It's covered with a collagen membrane. 6 months later, the second surgery, compared to the initial defect, it became very favorable. The patient was scared of dental treatment. Actually, he was internal medicine doctor. He didn't want the screws used for the block bone graft to be removed, so they remained there. After the surgery, immediate post-op and second surgery, and post-op 3 years, it is maintained very favorably. The patient is very happy because the previous implants gave him a lot of discomfort. In this case, we waited a little bit long for the posterior in the mandible. If there's no lingual bone, it could have been different. For the case under discussion, I believe this is similar to the case. Maybe I showed this in the case discussion before. The patient is a woman in the 60s. Number 6 is missing and very deep. If you place an implant very deep, in terms of perio or maintenance, it would be poor. There's no palatal bone. Looking at the adjacent teeth, I don't think it's easy to do GBR there. So I chose auto-block bone from ramus, and augmentation is done first, and then sinus graft, and I waited 6 months to place implants, and the crown root ratio is favorable. The last picture is a post-op 6 years. If I did not use auto-block bone graft, crown root ratio would become problematic. Maintenance would be hard if there's adjacent teeth. I believe the dentist who sent us the case I believe waiting can be a good option. In that case, when there are teeth on both sides, is it difficult to do GBR at one?
저 케이스도 그렇고 다 너무 어려운 케이스.
We are talking about all difficult cases, including this. My teacher once said, you need to be a good surgeon or good prosthodontist. Then we can address difficult cases. Looking at the cases introduced today, I believe you are very good surgeons to do GBR or even block bone graft, which is not easy for even periodontists. If they are placed deep, it's difficult to take impressions, and you try to address the problem with surgery, right? Vertical augmentation is always difficult. As I showed you in my first case, if you wait, it becomes more favorable than expected. Or in the last case of mine, if there's no palatal bone and if there's no bone in adjacent teeth, GBR would be very challenging. Autogenous block bone can work for augmentation and the maxilla, but in the mandible, if there's no lingual bone, it's very difficult. Dr. Kim Young-taek has prepared a case. Would you explain that, please? It is not a very difficult case. This is the case under discussion. The case is introduced by masters is extractions are made because of the periimplantitis, creating big vertical defect. This is the same case. I believe we will treat more of these cases in the future. The vertical defect of this has the characteristics that there is a huge vertical defect, but bone remain on the sides. Here, on the mesial side, the bone exists and also distally, so it forms a two-wall defect. Therefore, it is the environment where GBR can be done. I brought a case with me. If you look at quadrant 2, implants failed, so big vertical defect is created. This is the defect. I tend to wait sufficiently after extraction. As Dr. Kim Kyung-won said, but there's a situation, and if we wait to new options open up as bone is formed, I thought this much augmentation can be done. I believe we cannot augment bone for arbitrary height. It can be grown to this line, the line between the mesial bone and the distal bone, in very favorable environment and when the conditions are met. Let me show you a case. For vertical defect, it is very difficult to position implant. So surgical guide should be prepared before placement to find the position of the implant. If you look at the video, flap is raised and fixed. It is so deep you cannot reach. We cannot capture the point, so we access the from buccal side. Whether you place it deep or whether you do GBR, this is the placement point, and fixtures are installed. If you plan to do GBR up to this line, implants are placed matching that line, and the buccal side, the implant is exposed, and GBR needs to be done. So membrane covers the site first. Cover screws are connected. Membrane is applied. That should be applied first before bone grafting. Otherwise, you cannot position the membrane properly. The membrane is trimmed, applied, xenograft and alloplast are used together for the bone graft. Vertical defect is big, so 2 collagen membranes are used. Xenograft and alloplast in large volume is used. The membrane needs to be fixed. If you use the collagen membrane, you don't need to remove it. You talked about the screws remaining in the mouth before. I suture them, connecting the immovable tissue inside and the palatal tissue. I call it anchor suture to fix the membrane. Normal suture is done. Now it's completed. Even so, the distal side would be deep. If you consider the implant position below, you can see the shortened inter-arch distance. 6 months later, you need to wait long for vertical augmentation. It takes a long time to have bone matured, and the patient would accept that because there was no bone before. Collagen membrane doesn't have any problem. Healing abutment is connected. I always measure the period test, -7, -4. I waited 1.5 months, -7 and -5, and prosthesis was done. Vertically, the bone is grown. The experience from many GBRs that I have done, I realized that GBR is the cause of peri-implantitis. I want to avoid that as much as possible. I was curious of what the papers say. JCP and COIR journal were looked at, meta-analysis and systemic journal review. For the vertical ridge augmentation, there are many ways to do augmentation, distraction osteogenesis. I've never seen that or tried that, but surgeons would do that. And the GBR, which I do often, and the block bone graft. Most doctors would do GBR because it's less complicated, but still there are complications. In the systematic review, through meta-analysis, to raise augment to 4 millimeters, GBR is effective, but the complications, 12.1%. The problem is based on 1-year follow-up. There is a 5-year follow-up as well, but this is prospective studies. If you look at longer periods of time, this is the cause of the peri-implantitis. So in the papers, complications are always highlighted. Is it right to do GBR? Compared to CR ratio, if this has definite advantage, we need to go for this. This is not CR, but crown implant ratio, CIR. The ratio ranges from 0.86. The implant fixture is a bit longer, and the crown is twice the longer, that's 2.14. So there is no significant difference according to the systematic review in single cases, not splinted cases. And I looked at a very credible journal, the Journal of Prosthetic Dentistry. This is the meta-analysis. Marginal bone loss according to CI ratio. If a CI ratio is below or equal to 1.15, bigger than 1.07 millimeter, below 2, 1.32 millimeters. Bone loss according to CI ratio, there's no significant difference. Of course, the bone loss would be bigger with a bigger CI ratio because of the direction of applied force or others. However, it didn't affect implant survival. And the marginal bone loss is very small, 1.3 millimeter or so. So in conclusion, in this patient, we need to raise the flap to see there is a remaining lingual bone.
그리고 이제 앞뒤 본으로 임플란트 심었을 때
when implants are placed, whether they can be covered properly.
의 양상을 좀 봐야 될 것
I
같아요.
need to look at the defect of the bone.
심을 수 있으면 저 정도 심을 수 있을 것 같아요.
We can place implants like that
여기까지 심고
to the line,
크라운하는 방향.
and the crowns can be delivered.
복사해서 한번 만들어
I copy the crowns, and the crowns would look like this.
요 상에서 보이는 본 안쪽에. 그러니까 타협을 어느 정도 한 거죠.
It is compromised. It didn't go really deep, just below sinus. At the top, we can do bone graft, not GBR. Even we do GBR, small scale GBR is better. If you look at the height of the crowns, it's not really bad.
저게 저렇게 그려져서 크라운이 그려져서 그렇지. 사실
Prosthetic abutment
도철 어버트먼트 형
needs to be considered. Then it is not really unfavorable.
원장님 보여준.
As Dr. Kim said before, this is not too long.
근데
According to the paper reviews, 2:1 is not considered really bad. I believe this is 1.8 to 1. If you look at quadrant 1, it is less than 1 to 2.
이제 우리가 마주
So the vertical defect, we can do
것인가 뭐
GBR or
것인가 되게 많이
bigger CI ratio.
어
If implant can be
고정이 확실하고
stabilized and there's a bone,
관리를 좀 해야겠다는 좀 그쪽 관점.
the long crowns can be a good option rather than GBR. I know it's not typical statement from a periodontist.
네, 세분 원장님 교수님께서
So we have looked at various issues we need to consider. Dr. Kim Young-taek gave us very good summary. What about other doctors? Coming back to this case, do you have any other comments to make? As Dr. Kim Young-taek said, we will treat this kind of cases more. We placed so many implants and many of them not ideally.
소실돼서 없는 경우가 많기 때문에 정말 이런 거에 대한 공부를 열심히
We need to study these cases more diligently.
우리 치과 교수님까지도 뭐 저렇게 얘기하시는데 어쨌든 저는
So periodontist even said so. If the conditions are too tough, we need to wait.
생각같이 두려워할 요소는 아니에요.
Crown root ratio is not something we need to be scared of. Thank you. Dr. Kim Gi-sung and Professor Kim already said, when I was young, I tend to be aggressive in surgeries. Looking back, as Dr. Kim Young-taek said, GBR, the 1-year follow-up looks good, but in terms of longer term, 5 to 10 years, GBR can cause peri-implantitis, then we need to be more conservative. I also say that in my lectures. According to journal, if somebody else is doing something new, if that is easily accessible, and if it is predictable, and if it can be reproduced as others are doing, in terms of those, a sinus graft is the answer. If you have abundant experience in sinus graft, you can go for GBR, as Dr. Kim Young-taek said. Distraction osteogenesis is very hard to apply to implant cases. At one time, it was a trendy practice among surgeons, but it doesn't have very good long-term outcome, and the augmented volume is not very high, so I tend to be conservative these days. The case under discussion, right after extraction, it would look very challenging, but if you wait several months, more options will open up for you.
네, 케이스 디스커션 이번 시간은
In this case discussion, we talked about GBR and the prosthetic compensation when we have a vertical defect. I would like to thank the dentist who raised the case and viewers for participating. And I would like to thank 3 doctors who
지금까지 진행해
gave us good advices. I am Dr. Jang Young-eun, and I'll see you next time. Thank you.